Today I'll be presenting our findings from our study, the long-term impact of a liver function test pathway with reflex AST testing on early liver disease detection. Next, please. Chris, next, please. Thank you. Chronic liver disease is a major global health challenge with substantial healthcare and economic costs. It progresses gradually from healthy liver to fibrosis and compensated cirrhosis, and then to decompensated cirrhosis. Once cirrhosis develops, patient will face a higher risk of complications, and healthcare system will also face the rising costs. And therefore, early detection of liver disease is essential for timely intervention to prevent progression and reduce disease burden. There are two key time points in the early detection of liver disease, which is first, before the development of cirrhosis, and second, before the development of hepatic decompensation if cirrhosis is already there. Next, please. There is a growing interest in using non-invasive fibrosis assessment tools for early detection of liver disease. One of them is the well-established marker is the aspartate aminotransferase to alanine aminotransferase ratio, which is AR for short. It is low cost and highly available in primary care. In Wales, the reflex AST testing, which will enable the automatic AST-ALT ratio reporting and then a prompt referral, was introduced as a part of Brain AST project in 2016. And after 2 years, it was then implemented in Clontarf Morgan University Health Board in 2018. Our previous study showed a 81% increase in the new cirrhosis diagnosed in annual Bevan Health Board within 2 years of the implementation. But our previous study lacked a control group, which limited the causal interpretation because the observed increase might be attributable to a general increase instead of the effect of the intervention. Next, please. So the objective of our study is to assess the long-term effectiveness of the introduction of reflex AST testing by evaluating its impact in two Welsh regions, the Edinburgh Bevan University Health Board and Clontarf Morgan University Health Board. We want to qualify the changes in the liver disease early detection. One of the outcome, Chris, would you please click the slide, please? Yes, one of our primary outcome is the non-cirrhotic and compensated cirrhosis liver conditions. And this include the underlying liver condition, including metabolic dysfunction associated fatty liver disease and compensated cirrhosis, fibrosis. And then we also want to focus our attention to the detection of hepatic fibrosis and cirrhosis itself. Next, please. We use Cell Data Bank as our data source and linked primary care data from Welsh longitudinal general practice and secondary data from patient episode database for Welsh. Our study population extracted all individuals identified from GP and PEDU dataset and included all individuals diagnosed with NCC liver conditions from 2010 to 2023 and across all the 7 health boards in Wales. Next, please. So the introduction of reflex AST testing was first introduced in annual Bevan Health Board and then in Clontarf Morgan University Health Board. So the two intervention groups are annual Bevan and Clontarf. And the remaining 5 health boards are defined as control, which is basic Cartwater University Health Board, Cardiff Vale University Health Board, Howell Tar University Health Board, and Poise Teaching Health Board, and Swansea Bay. And the time frame for annual Bavin household is the pre-intervention period is defined as from 2010 to 2016 July, and then from July the 4th of 2016 to the end of 2023 are the after intervention period for annual Bavin. And in Kundaf University Health Board, the before intervention periods defined from 2010 to 2018, the end of February, and then from March the 1st, 2018, when the reflex ASD testing was introduced, and until 2023 was the after intervention period for Kundaf. And our primary outcome is the monthly incident rate of NCC liver conditions, and our secondary outcome is the incident rate of cirrhosis and fibrosis. Next, please. We applied a difference in difference analysis comparing the impact of the intervention on early detection of disease by detecting whether there is a significantly difference in the change of each of the outcomes. We applied both Bayesian regression, which will produce incident rate ratio as the effect estimator, and linear regression model, which will estimate an average treatment effect on the treated. So an assumption of difference in difference analysis is that the pre-intervention trends must be parallel between the intervention and the control groups. We tested the parallel trends assumption using Ward test and visualize it with transplot. Next, please. This cohort is extracted based on our previous work, and after applying inclusion and exclusion criteria, we identified a total of 78,917 individuals in total, and which includes 15,064 from annual Bevan household and 10,504 from Kuntaf, and 53,349 from the remaining control household. Next, please. The demographic characteristics are quite similar across all the groups, with a median age from 57 to 59 years old, and a proportion of males ranging from 49 to 52% across all the groups. And we observe a higher percentage of individuals from the more deprived areas in both annual Bevan and Kuntaf Health Board, with 32% of them living in the most deprived areas. While in the control groups, the proportion of people living in the most deprived areas are about 21%. Next, please. So here's our result. In annual Bevan household, the mean incident rate of NCC liver disease increased from 9.10 to 19.2 per 100,000 inhabitants in annual Bevan, and compared to 10.3 to 16.7 in the control areas. Our difference in difference analysis did not show a significant intervention effect for NCC disease detection. And for cirrhosis, cirrhosis incidence increased from 0.8 to 1.6 in annual Bevan household, and compared to 0.7 to 1.3 in the control areas. And for cirrhosis outcome, Bayesian regression showed a 10% greater effect, but linear regression showed no significant difference. And considering our outcome is incident rate, it is count-based, and also for cirrhosis, it is bounded between 1 to 3. So we consider Bayesian regression more appropriate for our result. When we restrict our analysis to primary care setting, neither of these outcomes or the models demonstrated a significant change. Next, please. So in Clondalk Moore University Health Board, the NCC liver disease incidence increased from 9.7 to 20.5 in the intervention group, and compared to 11.2 to 17.4 in the control areas. And this time, difference in difference analysis detected a 40% higher intervention effect in Clondalk University Health Board. And for cirrhosis incident, it increased from 0.8 to 1.8 in the intervention group, and compared to 0.8 to 1.3 in the control areas. And again, our analysis showed a significant 40% higher intervention effect in Clondalk. And this elevated impact was also detected by linear regression model this time, with the incident rate of NCC diagnosis increased by 4.5 additional cases per 100,000 population, and cirrhosis diagnosis increased by 0.5 additional cases per 100,000 compared to control group in our analysis. And when we restrict our analysis to primary care setting, the Poisson regression was able to detect 10 to 20% higher impact in both NCC diagnosis and cirrhosis, but not the linear regression model. Next, please. So yeah, so we investigate the impact of introducing reflect AST testing as a tool for improving early detection of liver disease, and observed a significant intervention effect in the Clondalk University Health Board for both early stage NCC liver disease and cirrhosis, but more modest or even inconsistent effect in annual balance health board. And we consider these differences cannot be fully explained by demographic or deprivation of the population, because both areas are neighbors and they share quite similar profiles. One of the possible explanation is the timing of the implementation. Because Clondalk implemented the same pathway 2 years later and may have benefited from prior lessons in annual balance health board. This may have resulted in better clinician awareness, more streamlined referrals, and stronger GP and patient engagement. And this highlights the importance of evaluating how these services are delivered, and it's not just whether they are available. But if we want to understand the underlying reasons in the differential effect of intervention, we must know that these clinical pathways may have evolved several steps, which include first, test uptake, referral imaging, and final diagnosis. And further research should include these factors. Okay, so time is limited, so I'll just wrap up. Our finding demonstrated the power of linked data to identify what works, where, and for whom, and supported more effective service delivery, and highlight the importance of implementation strategy and the need for further research to optimize the early disease detection. Next, please. Okay, thank you very much for listening. I'm sorry for the time taken, and we would like to acknowledge Cell Data Bank and Liver Disease Screening Partnership and all of the team members involved in this work, and have to take any questions if there is time.